Alright, YouTube, I got one here from iocdf.org titled Olfactory Reference Syndrome Problematic Preoccupation with Perceived Body Odor by a person called Catherine Phillips, MD. And this article was initially published in the winter 2018 edition of the OCD newsletter. Reading, Kyle is a 37-year-old single white male who believes that he has severe halitosis, bad breath, and flatulence, which makes him stinky and smelly. He states, quote, I know it's true because I can smell it, and why would people touch their face, sniff, and move away from me, end quote. To minimize the awful odor that he is certain he emits, Kyle brushes his teeth for about an hour a day, which has damaged his gums and tooth enamel. He gargles with prescription-strength mouthwash about 20 times a day, wears lots of cologne, changes his underwear many times a day, and washes his clothes twice a day, because he is embarrassed by the quote-unquote horrible odor he believes he emits. Kyle avoids most situations, or rather Kyle avoids most social situations. Sorry about that. He does not date and has dropped out of college. Unable to work, he spends most of his time alone in his apartment. He states, quote, I have to stay alone because I stink so much, and if I go out, people will make fun of me, end quote. Kyle is experiencing olfactory reference syndrome, otherwise known as ORS, an under-recognized disorder characterized by preoccupation with the false belief that one emits a foul, unpleasant, or offensive body odor. The preoccupation causes significant distress or impairment in functioning, for example, avoidance of social situations. Although people with ORS believe that they really do smell bad, other people cannot detect the body odor. ORS usually triggers excessive repetitive behavior such as repeatedly checking oneself for body odor or excessive clothes laundering. As a result of these concerns, social anxiety and social avoidance are usually prominent, and the odor concerns are distressing and impairing that suicidal thinking and suicide attempts are common. It says 1 through 6 in parentheses. I think that might be... Let's keep reading on. ORS has many similarities to body dysmorphic disorder, BDD, which is characterized by distressing or impairing preoccupation with slight or non-existent flaws in physical appearance, and obsessive compulsive disorder, OCD, 2, 3, and 6. That has probably something to do with the DSM here, criterion and whatnot. Okay, so our understanding of ORS and its relationship to other disorders is limited by a lack of research studies. However, ORS is not a new phenomenon, and it has been consistently described around the world since the 1800s as a distressing and often severely impairing disorder, 2, 3, 7, and 8 in parentheses. The large study comes from Japan, Canada, Nigeria, Saudi Arabia, Brazil, and the United States. And in parentheses it says 1, 6, 9 through 13. Diagnosis status of ORS. A Google search of ORS yields approximately 590,000 results, reflecting the public's interest in this concern. Efforts were made to add ORS to the Diagnostic and Statistic Manual of Mental Disorders, 5th edition, but research evidence was considered too limited to include ORS as its own disorder with full diagnostic criteria. Instead, DSM-5 lists ORS as an example of, and quote, other specified obsessive compulsive and related disorder, parentheses 14. DSM provides a very brief description of ORS's key clinical features, but does not include full diagnostic criterion or discussion in ORS in the text 14. However, the recently published International Classification of Diseases 11th edition, ICD-11, did add ORS as a new separate disorder in the chapter of obsessive-compulsive or related disorders. Alongside BDD and OCD, see box 15. It is... Okay, sorry. Intonation there. It is hoped that inclusion of ORS in ICD-11 will foster much-needed research studies and enhance understanding and recognition of this often severe and unrecognized condition. Clinical presentation of ORS. Preoccupation with perceived body odor. And individuals with ORS are excessively preoccupied with the belief that they emit an unpleasant or foul body odor, most commonly bad breath or sweat, see table 1. They believe that the foul odor emanates from body areas that correspond the type of odor. For example, bad breath from the mouth or sweat from the armpits or skin. Occasionally, the perceived odor may smell like non-bodily odors such as ammonia, detergent, or rotten onions, but most but not all people with ORS report actually smelling the odor. Insight and referential thinking. Most people with ORS are completely convinced that they actually smell terrible, despite the fact that other people cannot detect an odor. Very few recognize that their belief about the body odor is inaccurate. 6. Parentheses 6. And the likely explanation for this mistaken perception is that people with ORS report that they actually smell the odor themselves. See Table 1 and 6. Alternatively, those who do not smell the odor base their belief on misinterpretation of other people's comments, gestures, or behaviors. For example, if someone opens a door, touches their nose, moves away, or says it's stuffy in here, people with ORS typically and mistakenly believe that their unpleasant body odor is the reason for such behavior. See Table 1. And this inaccurate belief that other people are taking special notice of them in a negative way because they smell bad is known as referential thinking, or as ideas or delusions of reference. And excessive repetitive behaviors. People with ORS experience their preoccupation with body odor as highly distressing, and it triggers upsetting feelings such as depressed mood, anxiety, and self-consciousness. For this reason, nearly everyone with ORS feels compelled to perform repetitive behaviors intended to mitigate, check, mask, or reassure themselves about their perceived odor. The most common behaviors are smelling oneself, excessive showering, and frequent clothes changing. See Table 1. Camouflaging the perceived odor. People with ORS attempt to mask the perceived body odor, often with excessive perfume or powder, chewing gum, excessive or strong deodorant, or mints. See Table 1. This behavior can occur repeatedly throughout the day. And functional impairment. ORS typically impairs functioning, which can range from mild to extreme. On average, impairment is severe in clinical samples of individuals with ORS, parentheses 6, nearly 3/4 of people with ORS report periods during which they avoided most social interactions because of their ORS symptoms, and about 50% of reports during which they avoided most of their important occupational, academic, or life activities because of ORS symptoms. 6, see Table 10. Some people are completely housebound because they feel too distressed, self-conscious, and embarrassed about the perceived odor to be around other people, or because they fear offending others with their smell. High rates of psychiatric hospitalization, suicidal thoughts, suicide attempts, and a completed suicide have been reported, which many individuals attribute primarily to their ORS symptoms. See Table 1, 1 through 6, or 1 and 6 in parentheses. Comorbidity. Comorbidity. Commonly co-occurring disorders are a major depressive disorder, social anxiety disorder, drug or alcohol use disorders, obsessive compulsive disorder, and body dysmorphic disorder. And prevalence and demographic characteristics. In one study, 60% of individuals with ORS were female, and most were single. And the prevalence of ORS is not known because it is certainly more common than generally recognized, in parentheses 2, 3, and 16. What causes ORS? The cause of ORS has not been studied and thus is not known. Like other psychiatric disorders, its cause likely has many genetic and environmental determinants. ORS has similarities to BDD, OCD, and social anxiety disorder, and thus it may share the same etiologic and pathophysiologic characteristics with these disorders. For example, ORS may involve abnormalities in the brain's olfactory system that cause olfactory hallucinations or sensitivity to odors. However, this theory has not been studied, and it is likely that it is not relevant to the minority of those with ORS who do not actually smell the odor. Treatment for ORS. Medication. No prescribed medication no prospective medication studies have been done, either controlled or open-label studies. Case reports and small case series describe improvement with serotonin reuptake inhibitor, which is known as they used to be called SSRIs, but they're just calling them SRIs here. Monotherapy, neuroleptic, which is antipsychotic monotherapy, non-SRI antidepressants such as tricyclic antidepressants, or a combination of a neuroleptic and antidepressant medication 2 through 4. In the author's clinical experience, SRIs at high doses often effectively treat ORS. Psychotherapy. Reports on psychotherapy are similarly limited to single case reports and small case series in which report improvement with behavioral therapy, cognitive behavioral therapy, and paradoxical intention 2 through 4. In the author's experience, cognitive behavioral therapy, consisting of cognitive restructuring and advanced cognitive strategies for core beliefs, including self-esteem work and self-compassion, ritual prevention, and exposure-based exercise, along with behavioral experiments that are tailored to ORS symptoms, can be effective. ORS's clinical features appear most to those of BDD, and an evidence-based CBT treatment manual for BDD can be easily adapted to treat ORS symptoms. 17. Non-mental health medical treatment. Nearly half of people with ORS seek non-mental health medical treatment for their perceived body odor, many before seeking mental health care. In one study, 1/3 of the people actually received such treatment. And patients may consult dentists, surgeons, and ear, nose, and throat specialists for supposed halitosis, proctologists, surgeons, and gastroenterologists. That's a hard one. Gastroenterologists for supposed anal odors, and other physicians such as dermatologists and gynecologists. Treatments such as tonsillectomy for perceived bad breath, or electrolysis of sweat glands for perceived sweaty smell may be received. Such treatment does not appear to be effective for ORS symptoms and often leaves patients dissatisfied. A neurological workup, which may include an EEG, which sometimes may be warranted to rule out a neurological explanation such as a temporarily lobe epilepsy or migraine aura, for perception of an odor that others cannot detect. The kind of evaluation is more relevant when concerns focus on non-bodily odors and occur only intermittently. Recommendations for clinical care. Current understanding of ORS is substantially limited by the very small number of published and research studies on this condition. Nonetheless, it is important for clinicians and the public to be aware of ORS. Table 2 provides some clinical recommendations based on current research-based knowledge about ORS and the author's clinical experience. More research studies on all aspects of ORS are greatly needed to advance the understanding and treatment of this condition. And so they kept talking about a table. I don't see a table here, but we're doing pretty good in this article. Not a lot of errors. I did pretty good on that one. I'm pretty proud of myself. But the reason why I read this article, I don't know if you guys remember, I did a vlog about like 3-4 weeks ago where I was talking about this. I was talking about how I've kind of basically self-diagnosed myself with this. And it's pretty difficult. And I guess, there is some comfort in knowing, not comfort, but some consolidation or some consolation knowing that other people are dealing with this as well, and it's all over, right? I'm worried about everything smelling bad, so it's kind of like, it's a struggle for me, but I will say that I have, embarrassingly enough, I have actually asked my coworkers about this, and I've asked my boss about this, somebody who has to be honest with me. None of the coworkers say they ever smell anything. My boss says he never smells anything, and it's like, it's very, you know, it's very reassuring to hear that. It's very comforting to hear that, but it's also not total consolation, because I'm always going throughout my shift, always fearing that I'm going to smell bad for my clients or for the clientele there, and but it's never something that is a problem apparently. And there was an incident actually a week ago where this fellow was eating at a restaurant with his family, or with his wife and kid. And what I guess he must have been drinking, but he must have been pre-gaming before he actually came to our place. But the dude, like, just totally, like, you know, he passed out in front of the bathroom door, and then he got up, like, shot up, and then, like, puked in our trash can outside, like, you know, where we're supposed, you know, where our station is. And it was really bad. It smelled really bad, and one of the hostess who's like up at the front part of the restaurant came back and said, "Oh, it smells bad back here." You know, it's like the other time she walked back here, it's like she never said that, but just right after the guy happened to throw up, it's like, well, shit, yeah, no wonder it smells bad. I smell it too. And as far as hallucinations go, I don't have those, and I'm very glad to hear that. And it's pretty alarming to hear that people have actually had hallucinations, and it makes sense, I guess. Like, there's some kind of malfunction with the olfactory reference, or rather with the olfactory system, or whatever, sense of smell, in other words. So yeah, all right, guys, thank you so much for watching. God bless, and I will see you after I get off work. Goodbye.